I'm pleased to introduce to you our final speaker of the day, Robert Tombly, who is a lead data architect at the UCSF Center for Clinical Informatics and Improvement Research. Robert, I will give you the floor.
Thank you. Let's see. There it is. All right. So thanks everyone for coming today. My name is Robert Tombly, as Christina said. I'm the lead data architect for a small research center in the Department of Medicine at UCSF. I've got fairly deep experience working with all kinds of healthcare data, particularly in health services research, but also in clinical research, quality improvement, and clinical informatics. I've got a pretty nonlinear background. I've worked in education, engineering, oceanography before coming to medicine. I've spent my career, however, immersed in data and working to help use data to teach others. I live in Petaluma. In fact, we had a power outage today, and it was like a whole thing living in Petaluma, but I'm here now with my wife and 2 boys. I'm a huge Giants fan, many other hobbies, but and we actually just got back from Scottsdale. We went to spring training and saw a few Giants games there. So that's who I am. My talk today is going to focus on the main thrust of my day-to-day work, which is audit log research. So feel free, as I'm talking, to type in any questions that come up, audit log or not. I will try to either address them as I'm speaking or during the Q&A session at the end. But if for whatever reason I don't answer your question, or you think of one later, or you just want to connect, I'll happily share my email, and feel free to reach out, ask me any questions. I'm excited to talk more about this or anything else. So I wanted to start off with a really obvious statement. Healthcare is a complex, messy human process. I don't think I'm surprising anyone by saying that. As a microcosm, though, of this complexity, I want you to imagine yourself in a single hospital room. So maybe it's a hospital room that you're in as a patient, maybe it's a loved one as the patient, or maybe it's a hospital room that you're working in. And I want you to imagine that everything that's going on around you, with you, to you, in the room as you're sitting there. So what you're probably imagining in that one day in that one hospital room is hundreds of human interactions between patients, nurses, physicians, technicians, phlebotomists, many others as they come and go in the room. Dozens of clinical actions, decisions, non-clinical actions, procedures, transactions, and then interplay between the people and the built environment, interplay between the social and cultural environment, and even the digital environment like the EHR or other digital tools. There's monitors, there's sensors. So in this one room on this one day, there's a ton going on. And at a health system level, reliably capturing this amount of activity and extracting meaningful information about this healthcare or this patient care is really, really hard. It's super complex. In fact, I tried to track down a quote for this talk. I couldn't find it, so I'll paraphrase. But basically, I saw that someone once said, healthcare is perhaps the most complex creation ever developed by human beings. So in order to manage all that complexity, we need help. The way we've decided to do that is through abstraction. So we're designing coding systems, frameworks, claims forms, metrics, guidelines, modern healthcare, in order to reduce this complexity down to manageable levels. So these abstractions, they take what's in effect infinite complexity, and they try to describe them in a finite way that may not be perfect, but sometimes it works, and it mostly allows the system to function. So these abstractions are key to business and care delivery side of healthcare. It's how the money flows. So as a result, anyone who's trying to understand healthcare, so that is folks doing quality improvement, management consultants, researchers, analysts, senior management, clinic managers, whoever, they're going to rely on these abstractions to inform them of what's happening at the bedside. And so data that's built on these abstractions has become the bread and butter of healthcare delivery analysis because it's reliably connected or collected, it's affordable, it's attainable, and it uses standardized systems and practices so people, nationwide can communicate about the same things. the majority of research and measurement of healthcare practices are enabled by these types of data sources. So we're talking claims data, chart abstractions, regulatory data like MIPS or HEDIS measures, surveys, interviews, what have you. All of these are data sets that are enabled by these abstractions. So these abstractions, by necessity, paint a hazy, low fidelity picture, though, of what actually happened. The dizzying complexity that we talked about and imagined just a few minutes ago. Fully understanding healthcare delivery requires an appreciation and a window into the context that's surrounding what you can think of as the bullet points of healthcare. So this context is all too often missing from traditional sources of healthcare data, despite how integrally tied to outcomes of care this context actually is. So as I mentioned, traditional sources of healthcare data capture the focal points. The providing, billing, rendering MPI, the POS codes for the billing entity, reimbursable condition or procedure codes, CPT, ICD-9 or 10, outcomes, what have you. So collectively, these sort of extracted data form an outline of the care provided. An outline that's totally sufficient for TPO or other management activities and a lot of research. What's missing from all of this is the other stuff that's happening in that room, away from the focal points. But it's certainly part of healthcare. So things like who else was helping care for the patients? Nurses, security guards, medical assistants, all the stuff that gets rolled up into the like hospital billing component of the claim. Like who is actually doing that? Often we don't know. It just gets rolled up into a single charge. Where else was care delivered besides the billing entity? What non-clinical care was provided? How was nursing provided at the bedside? Often that doesn't get reimbursed, and so we just have no window into what was actually happening at the bedside from nurses. And then what non-billable clinical actions existed? So things that maybe can't be reimbursed, and so they don't get recorded on a claim form, but they're still very, very possibly impacting outcomes. And then more recently, what digital information was being consulted and considered during care delivery. So all of this together, we term context. And so you can think of reality, what actually happened, minus the context, is this abstraction. And so you can kind of use some algebra and reconfigure your equation. Another way of saying that is reality is just abstractions plus context. And so abstractions are totally useful. I don't mean to say that this data is not useful. Abstractions are the bread and butter of management, research, and improvement activities. For a lot of research questions, it's sufficient. So it's only sufficient, though, when the questions we're trying to answer are aligned with the information retained by those abstractions. So by way of an analogy, if all we had to go on was black and white photos of an operating room, we might be able to tell if the surgeon count improves surgical outcomes because we can count the surgeons in the picture. But what we wouldn't be able to tell is if the color of their scrubs impacted hospital-acquired infection rates. So perhaps that's a research question that someone would want to ask. You couldn't use this abstracted data to answer that question because there's no color. And so the idea is that most of the time abstractions are sufficient, but for a lot of other questions that haven't been asked, we need more to go on than what is commonly available. So the work that I'm involved with, the work that our center works on, is really trying to ask a specific question, which is, can we recover some of the context that's lost through abstraction and enable new types of research and improvement activities? So how do we do that? Well, it's certainly hard to do, staring down the infinite. We got lucky. So love it or not, healthcare in 2023 has become tightly integrated with the EHR. To understand EHR use basically is a decent proxy for understanding healthcare delivery. Certainly not perfect, but it's certainly a higher fidelity portrait of what's occurring at the bedside than merely relying on claims data or chart abstractions or even surveys. And so at the same time, not only is EHR the EHR use tightly coupled with care delivery practices, it's also nearly ubiquitous, at least in the US, certainly in hospitals. So thanks to more than a decade of government incentives, that's where we are today. We're at this like mesa here of the blue line, where we are about as fully populated in hospitals as you can imagine we could get. And so the EHR is everywhere, but it's not helpful that there's no way to actually measure what's happening in the EHR. And luckily, in 2015, ONC ushered in a new era of EHR use measurement by mandating the inclusion of audit logging within all certified EHRs. So by 2017, that's basically every EHR. And ostensibly, what this audit logging is there for is to understand and ensure that people aren't looking at patient data that they're not supposed to. But there's a side effect, which is that this mandated audit logging, what we're soon going to refer to as event logging, allows us to piece together a really high fidelity account of EHR use and extrapolate that to piece together a better picture of care practices and more a better understanding of the context surrounding care practice than we've ever reasonably been able to do before. Certainly, we could have done this by putting a researcher in at the bedside and recording everything we saw, but that's prohibitively expensive and just not feasible for most projects. So as a result of this, Dr. Julia Adler-Milstein, who's my boss, she is an internationally recognized expert on EHR use. She specifically around adoption and interoperability and digital health policy. In 2017, she left the University of Michigan to come to UCSF. She founded a collaborative research center called CLIR, which stands for Clinical Informatics and Improvement Research. And we are really there to understand clinical informatics and the study of digital health tools and their impact on patient outcomes and health system performance. The cornerstone initiative of CLIR is using this EHR audit log data as a tool for unlocking context within healthcare and as a gateway for novel research into healthcare and clinical work practices. So what is audit log data? That's a good question. So before we dive too deeply into what audit log data is, I want to be clear about terms here. There's a audit log data is a concept that's thrown around kind of a lot. They begin as a specific concept, which is what we usually refer to as event log data. So this is the auditable trail of every action taken by every user in the system. What's happened, however, is kind of maybe like Kleenex has become to be a synonym for any sort of paper product. That the term audit log data has come to represent kind of a style of data rather than one specific product. So people often say audit log is a generic term that can variously refer to event log data, such as Epic's access logging, which is mostly what we're going to discuss today. It could also refer to efficiency tracking data, which is usually focused on time spent by users in particular areas of the EHR. So examples include signal data or UAL light data. And then there's what is often the most fruitful source of audit log data, which is actually just the metadata that's recorded alongside the clinical data. So if you're documenting in a chart, this might be the order placed by a physician or the progress note written by the physician. That's the clinical data. But alongside that clinical data is the time that the note was signed, who did the signing, who dictated the order, who actually entered the order into the system. All of that is context and is what we term like the digital scraps that help inform and colorize the picture of what's actually happening. So all of these together kind of form an audit log data approach. So just to not confuse you, there are three kind of pillars of this audit log data approach, and event log data is kind of synonymous with audit log data, but it is important to distinguish that there is more than just event log data in this realm. So as I said, so when you hear about audit log data, you have to be paying attention because the author might be referring to a bunch of different concepts, but typically they're referring to audit or event log data specifically. This is typically the foundational data type for this kind of work. So focusing on the event log, what's referred to as access logging with an Epic, as I mentioned, is ostensibly designed to audit user access. So where are all of the users in the system actually going and whose data are they looking at in case they need to make a case for HIPAA compliance or whatever. So over time, the areas of the EHR that this tool, this audit track covers have expanded. And now we have a really high resolution portrait of behavior of every single user of the EHR across the breadth of the EHR. And if those of you who are familiar with Epic, that's very, very broad. And so it's extremely valuable, although it's a massive source of contextual information. So what does it look like? So the event log, audit log, access log data looks kind of slightly different between vendors, but generally it looks something like this. So you have a huge number of action types. So there's about 2,000 distinct actions within Epic, and it varies by vendor, and that the user could be doing, such as the user logging in or out, opening a patient's chart, viewing or signing a progress note, launching a check-in activity, launching a results review. These are all sort of action types. So that's what's recorded here. It tells you what did the user do. Each of those action types can be triggered by a user doing that action. And so when that action occurs by a user, a new row is added to the event log, and that row has a time that it took place. So here, January 3rd, 2022 at 11:11 p.m., 5 seconds. Who did the work? Who took that action? So in this case, Dr. Jane Smith. Where they did that work. So this case, it's workstation or computer number PN662413 AIO. That's an all-in-one. That's one of those funky stand-up stations that you see in the doctor's office that have the computer and the monitor all together, and you can roll it around. And most actions, at least ones that refer to patient data. So obviously, user logging into Epic, there's no patient associated with that. But opening a chart, there's certainly a patient associated with that. So these are associated with specific patient MRNs, and in most cases, an encounter ID. So this is like, which encounter did they look at, or which progress note, or which appointment was this associated with? And so someone just asked, when nurses providers don't chart in real time, how's the event log data affected? Great question. So basically, when they don't chart in real time, it charts at the time that they enter the information into the system, not the time that it was ostensibly documented. So in other words, if you had a 10 a.m. appointment and you were writing a progress note about that 10 a.m. appointment at 9 p.m., the audit log would show 9 p.m., not 10 a.m. And then for some piece of information, that's valuable. For others, it's a problem, and you have to kind of try to back out exactly when or which encounter you were supposed to be referring to at the time. That's just an example of one of the many challenges with doing this work. But you can see it's got a really high resolution portrait of what's actually happening in the system. And this is for every single user. Doesn't matter if they're a physician, a nurse, a technician, a security guard, the CEO of the system logging into Epic to see what's going on. Everyone gets recorded as long as they're logging into Epic or whatever audit, vendor you use. So that was a great question. As a segue to this, there's some real pros. It's great for understanding context because it's recorded automatically. So that's actually a big deal. Often healthcare information is recorded in a biased way so that we are seeing there's incentives for putting it in at a particular time, for example, or there's incentives for some types of data to be input and others to not be input. This is recorded for everyone all the time, no matter what. It's recorded for all workstations and all users at all times. It's got broad and deep coverage. It's tied to specific patient records, and it also has a lot of, I'm not showing it here, but some of these actions also have additional contextual pieces of information. So for example, if it says clinical note signed, I can go and find out exactly what clinical note was signed, the note ID for that note that was signed. And so that allows us to reach out to the entire rest of the clinical data model, which gives us tons of additional context about what's actually happening. And then, as I mentioned many times, it's super high resolution. It's probably a higher resolution than most other data in Epic. And so that helps us create a really fine-tuned understanding of sequencing. So it gives us a window in the minutia of care. But the drawbacks are, it's usually considered PHI, so that is a big barrier. It's super large. As an example, there's about 40 million records per day at UCSF. So if you wanted to look at over a year, that's a ton of information. And as such, it's computationally and technically challenging to work with. A question in the chat says, do specifics for note records appear in that event log? So not sure I fully answer or understand that question, but I think what this person is getting at is, do we see in the event log, for example, was this a progress note, or was this note number 1, 2, 3, 4, 5, 6, 7, or who, like, what is the actual content of the note? Like, patient X is in a diabetic coma as of today. That you can all get to through a linkage, but all that's really recorded in the audit log is the actual note ID. And so we can then go out to the other parts of the data warehouse that store the actual note information to connect that. So the audit log itself is largely PHI free, except for the fact that there's a patient identifier and a CSN. And so it's challenging. All right. So that's the audit log data. And in a nutshell, and I want to go through 3 kind of case studies. I think I'm going to run a little bit tight on time, so I'm going to focus on hopefully 2 case studies, and then we can maybe touch on the third. But generally, we've done a lot of work around the audit log in a bunch of different domains, and the first domain is the American Medical Association. They've done a lot of work around provider burnout. Specifically as it relates to EHR burden and use, and increasingly around telemedicine adoption. So with this project, we sought to utilize audit log data in order to quantify provider documentation burden and assess the impact of CMS rule changes on that documentation burden. So in January of 2021, CMS adopted changes to the E&M billing documentation requirements. So E&M, evaluation and management visits, are kind of the bread and butter of primary care. They have a certain set of documentation requirements associated with them in order to bill at a higher level. Much of that documentation was considered highly burdensome and unnecessary. And so the AMA, in conjunction with CMS, adopted new rules that lessen that burden, or that were designed to lessen that burden. And so the question we had was, did that actually work? Did it actually reduce the overall burden that providers are feeling with documentation? Or is this just like a change that didn't have any real impact? So we sought to understand that through the lens of the audit log. So we adopted 3 EHR use measures. So that's EHR time, WOW, and doc time, in order to understand the impact of these changes on primary care physicians' EHR burden, EHR documentation burden. So I won't go in too deep here. These measures are not invented by us, but we developed the ability to use them within audit log data. I think they were originally designed for signal data, but we use them in when I say audit log, I'm doing it just like everyone else. I mean event log data, what I just showed you earlier in the talk. And so this allows us to measure their effect in depth at UCSF. We can get tons of granularity around who is doing this, when they're doing it, how long they're spending doing it, and that helps us answer more in-depth questions. And then we're also able to do this at scale by developing these for Cerner data using the Lights On network, which is kind of like Signal for Cerner data. And so briefly, we built 3 measures, and those are EHR time, the total time spent logged in the EHR. Wow, out of that total time spent logged into Epic, how much was before your first patient of the day and how much was after your last patient of the day. So it's kind of like work outside of your normal work schedule. And then doc time, which is just how much time did you spend writing notes, which is like the biggest burden of them all. So in practice, these measures are all severely impacted by patient volume. So we want to normalize them per encounter. And also we want to aggregate them over a week, because if you measure them at a day level, you end up basically seeing like, oh, so-and-so had 5 or 6 or 10 E&M visits today, but they had like 10 minutes on the EHR. Well, it's because the next day they're doing all their documentation. And so the next day they have no visits, but then they have 5 hours of documentation time. So we wanted to like expand this to a week level. So we're capturing both the visits that happen in a week and the documentation that happens, because they're not necessarily at the same time. This gets back to that question that someone asked earlier about like, is the audit log information tied to the moment it's entered into the system, or is it tied to the moment that the care practice happened? And so it turns out that there is a measurable effect. The total time spent on documentation per provider week by primary care doctors at UCSF went down. It's significant statistically, and there are insignificant changes or differences in their character counts per note. So effectively what that means is providers have gotten faster at putting their notes in, which is the intended effect. But, and we saw this both at UCSF using Epic data, but also in the Cerner Lights On network broadly, as well as at another site using Signal data, that it's significant, but it's on the order of seconds per week. Clinically insignificant. It's effectively not, it did not really do anything effectively. But, and this is one of the values of using audit log, is if we zoom down to the individual level, we see an interesting finding. So here, what you're seeing is each row in this chart is a different physician. We look at a huge amount of them. There's 61 in our study. But what this chart is showing is, to the right, these are people who have more time spent in the EHR, or spent writing notes in 2021 than in 2020, in the same sort of time frame. And then on the left here, on the bottom, are patients who spent significantly less time. And so while we, at an average level, are not seeing a huge change, at an individual level, there's huge differences. 20 minutes saved in a week is a massive amount from a clinical perspective. And so what the audit log data has shown to us is that there is potential value in figuring out who these specific users are and talking to them and asking, like, how do you do this? How are you being much better at entering your notes now than you were a year ago? Or vice versa, like, what's changed? Why is it so much harder for you to input or to write your notes now than it was previously? And so I just want to quickly look at, all right, so maybe I'll quickly show you two quick pieces from the next 2 case studies, and then I'll get to questions. So the next study, we basically looked at time to diagnosis in stroke patients. So people who have acute ischemic stroke have a critical time window for treatment. Every second without treatment contributes to additional functional decline. So what we want to do is we want to get them TPA as soon as possible after they arrive at the hospital. But you need to know if they're actually having an acute ischemic stroke and not an acute hemorrhagic stroke, which has similar symptoms, but if you give them TPA with a hemorrhagic stroke, they will bleed out. It's not good. So you need to be certain in your diagnosis as quickly as possible. So there's this concept of time to diagnosis. So what we wondered is, is it possible to measure non-clinical impacts on that time to diagnosis? So in other words, the context. So we I'll skip over some of the details. You can look back later. We constructed this across two concepts. So busyness of your environment and a team experience. So busyness was, you're in the ER, it's crazy, it's hectic. Does that amount of hecticness, both at a personal level or a team level, impact your time to diagnosis? And it turns out not significantly, or not statistically significantly, at least according to our data. And then we also looked at experience. Does your mutual experience shared between all of the pairs of providers on your treatment team impact your ability to quickly diagnose patients? And the answer is resoundingly yes. And so that's why we call this study Team is Brain, a riff off of Time is Brain. And the idea is that providers who work together in the last 6 months tend to have better outcomes than those who have not worked together before. And so all of this was enabled using the audit log, because we now understand who all of these people are that are able to, that are working together, and not just the bullet points of the patient or the team that are working together. So that the people who are getting paid, basically. And then the last thing I want to point out is, so some of you may be familiar with the concept of an age-friendly health system. It's 2,700 hospitals across the country are trying to implement this framework for age-friendly care, so care for older adults. There's a lot of clinical discussion of what should be done, but not a lot of ability to measure whether that gets done, because in an inpatient setting, so much of this is around nursing actions. What screening tools were used, and what nursing actions took place in order to prevent and manage delirium, mobility, high-risk medication use, and understanding what matters to the other older adult. So we developed a number of different measures for actually tracking this. You can see on the right here, we have a dashboard that shows on a reaggregated a monthly basis, but you can do it much more granularly, exactly to what extent 4M's compliant care was delivered in our inpatient setting at a given time across all of these different dimensions. And so most of these dimensions are dimensions that were not possible without audit log data to back them up, because so much of them are not abstracted. It's not abstracted information. So for example, the patient had adequate opportunity for sleep each day, or delirium screening was performed during each nursing shift. So all these are documented in the EHR, but in a way that doesn't make its way into billing. And so we're often unable to actually to see that, short of using audit log data. So a bit of a whirlwind tour through the case studies. I apologize, ran a little short on time. There are tons of other areas that can be enabled by audit log research: infection control, digital workflow design, employee retention, physical design, all sorts of other things. It's a surprisingly rich and untapped addition to the world of research and improvement and all kinds of healthcare improvement activities. The field is young, there's plenty more to do. We're starting to see a lot of interest and a lot of papers with significant and actionable findings. Thank you very much for coming. And please reach out. I'm happy to answer questions over email, and I will try to answer the 2 questions that I see in front of me now. And yeah, thank you again. And then to shift hats into the QA portion, I have one question. Is it possible to build some sort of KPI dashboard on a real-time basis? Device usage by location? Absolutely. Depending on what you mean by real-time, the way that this is extracted is it's pulled down from an unqueryable location once or twice daily. So you're going to have some lag, but it's near real time. But the rest of that is very doable. How do you address CPU issues that may arise around this large volume of data? So this data is not stored on your personal machine or any one workstation. It gets stored at a system level and upgraded or uploaded to the data warehouse. There's petabytes of storage and lots of CPU to throw at it. Having said that, it's not a minor consideration. Clarity, which is the Epic data warehouse, 50% of its footprint in terms of bytes is this audit log information. And so Epic is working on some way of archiving this information so that it doesn't become a huge burden over time. But it is, as I said, it's because it has patient safety implications, it's kept around, and there's incentive to keep it around, which is a win for us. And then does the audit log data help identify high-risk patients, looking at age, SES, race, etc.? So it can, but the problem with audit log data is that it is it's very raw. So you certainly could develop a metric using audit log data that might help you sort out care in the EHR practice patterns that are associated with higher risk patients. And you might be able to surface that, and that could help you identify high risk patients. But it's not like you just look through it and it's like, oh, there's a high risk patient, there's a high risk patient. You know, there's a lot of work involved in doing that. Be happy to talk more about that offline, but it's possible. Yeah, so those are the 3 questions I had. Any other questions? Or
Sounds like give you a few seconds there. That was 10 seconds. Thank you everyone for attending this final session of the day, and to Robert for such insightful knowledge on the EHR. I know this kind of touches on everyone's world in this conference today, and innovation around this is always evolving. So thank you. Again, thank you to all of our attendees today for attending this final session of the day.